notice that their airway is completely open. So anything that they want to get out, it's going to get out and it's going to stay out. And they're not lying down flat. نشوف the airway contradictions or what you should not do. Offering something to eat or drink. This is the worst thing that you can do because the airway was obstructed and they were not able to move air. So giving something to eat or drink is going to increase the risk. Just give it some time, and until they are cleared and feeling comfortable again or evaluated worst case scenario, then they can have something to eat or drink. A closed space. Many people are claustrophobic, or when they're getting too much attention, what will happen is they will not feel comfortable and they will start having annoyed breaths. They'll have dyspnea. So it's important to give people space so that it can help them relax, because this is also kind of psychological. The supine position is when we're laying flat. When we're laying flat, we have gravity, which is going to make it harder to breathe. We will look at that later. Plus, if I want to get anything out of my mouth, it's going to get out and come back in. That's not what's supposed to happen. It should get out and stay out. هلا بالbreathing. This is fun. So when we're breathing, I'm interested in what is going inside the body as in terms of muscles, the ones that are responsible. So first I have the diaphragm. When we breathe, the diaphragm will move downward, and the sternocleidomastoidus, this will lift the rib cage up. So what happens when the diaphragm moves down and the rib cage moves up? I am inducing a negative pressure ventilation. This is called negative pressure, so that the lungs can suck in air. So this is going to be very advantageous. I know the muscles involved now. And what can I observe to see whether or not my patient is breathing okay, or if they are having agonal breathing? I can look at the chest rise and fall simply. See that the chest is rising and falling will tell me that they are breathing okay and they are doing well. If the sternocleidomastoids are under tension, you know, when we take a deep breath and we have a tendency to put more muscle force from our neck to take a deep breath, this shows either it was a little bit hard to take that breath, or if it's an elderly person, it can be evidence that they're having some trouble breathing. So the scenarios is, if we have apnea or dyspnea, we will use rescue breaths, and this is the ambo bag. We call it a BMV, or bag, valve, mask system. That's the mask, that's the bag, and this is the valve. Now, this is going to be more fun, particularly for the biomedical students. This valve over here, it's going to switch to a different color. This valve over here is called the PEEP valve. This means positive because I'm actually pumping air into the person, and expiratory, expiration, positive, and expiration pressure. So what's happening with this valve, when I compress this valve is going to go up. It is spring loaded. It's going to go up. It's going to let the air that's coming in from this blue balloon, it's going to go into the person. And then when I stop, when it's taking air from the environment, that valve is going to close. It's not going to let the air come in. But what happens if, for example, the patient wants to breathe, it's going to open, the valve will get activated, and it will throw anything that the patient is aspirating, whether it's air or liquids, it's going to let them out safely. This is why it's called a positive end expiration pressure valve. This over here is an oxygen reservoir. This is the O2 tubing. And this is going to get connected to the pressure gauge of the oxygen tank. When I turn it on, this reservoir will become a nice, it will become a balloon of oxygen, and I'm going to be increasing the partial pressure of oxygen in the air. Not increasing the percentage or the percentage of oxygen in the air, just its partial pressure. When we go to a high altitude place, I'm being deprived of oxygen because its partial pressure is less, not its percentage. So that's what's going on here. And this is also a PEEP valve, but it's not spring loaded. I put my mouth over here and I put this over the patient's mouth and nose. This is going to be filled with air to ensure a good seal. And when I give a breath, I'm going to be injecting them as positive pressure into the patient. And if they want to aspirate anything to just get out of the side. It won't actually go into my mouth. There's that little blue thing that's like a diaphragm or filter. But this is what we would do if something is having trouble breathing or if they are not breathing. Now, let's talk about dyspnea, which is the shortness of breath. What are the causes and what are the treatments? So, pneumonia. Pneumonia, it is a chronic condition of the lungs where they will fill up with the fluid, and so we will not be able to breathe properly. Anaphylaxis, it's a life-threatening allergic reaction. And what will happen basically in anaphylaxis, if this is my bronchi and bronchioles, this is the trachea on top over here, this will begin to shrink as a result of the allergic reaction. So it's going to go from this to this. This is what we call a bronchospasm. The muscles lining the bronchioles, they are going to start spasming, which is why we call it bronchospasm. So this is why when someone is going into an anaphylactic shock, من بلش نسمعهم عم يعملوا that's a bronchospasm going on. They cannot take in air properly. A respiratory pathogen, of course, COVID-19. And COPD. COPD is for compulsive obstructive pulmonary disorder, which is where um, in the lungs you have a chronic condition. And asthma, الربو. So the treatment is a nebulizer with Ventolin, which is the brand name. This is a brand name. It's not a medication. It's the brand name of albuterol or salbutamol. These were when you inhale them, it will help the trachea and the bronchioles expand. And what the nebulizer basically will do, this is the nebulizer like this. This is to the patient. And this is to the oxygen. And over here, I'm going to put the Ventolin, and it's volatile. Volatile meaning that it will evaporate on its own. I'm going to mix some oxygen with the Ventolin. So as I'm breathing in more oxygen, and I'm breathing in the medication so that it can help open up the airways. So basically, you can think of a nebulizer like a bottle of deodorant. You just spray it, it has gas, and it has whatever other liquids or solutes are inside. Respiratory therapy, the PAP machine, في عندنا the CPAP machine, the continuous positive airway pressure machine, which is to help with people who have sleep apnea because they're not breathing correctly at night. Or we have the BiPAP machine, the bi-level positive airway pressure. We have oxygen administration, اللي هو اللي عم نعاني منه من وراء COVID-19. An inhaler. هلا the contradictions and what we can do. 45-degree back. If I am flat like this and I want to breathe, the principal part of breathing is the chest rise and fall. But there's gravity. The force of gravity is acting on my chest, so it makes it a little harder to breathe. And if I want to spit anything out or aspirate anything, it's going to be harder. So I put them at a 45-degree angle. This is gravity acting down, and this is the 45-degree angle. So the value of gravity, it is divided by 2 تقريبا. So it's easier for me to breathe, and if I want to spit anything out, it's easy. Give space, like we mentioned earlier. Relaxed breathing and call for help. Relaxed breathing is very important because then you would have over here 5 seconds deep inhale, and you feel your lungs filling up with air, and 3 seconds exhale. This calms you down, and and in your brain it will get the metabolism all right, and call for help if need be. Contradictions: offer liquids or foods. This is something very popular. In fact, people want to offer food and water if someone was not breathing, and if someone was talking. Don't do that. You're not supposed to. Why do you think they tell you don't eat a meal 24 hours before a surgery? Obstruction, choking. So this is what's happening. Put these in reverse a bit. Okay. So if the coughing is working to achieve aspiration, we will continue with it. If it doesn't, we will do the Heimlich maneuver of the abdominal thrust. We spread the legs of of the person who is choking, and I'm going to put my foot between their open legs. This way, I get their center of gravity closer to me so that I am in control. So if they want to fall over, they're not going to fall over. I'm going to make a fist with one hand, and I'm going to put it thumb in first, just above the belly button. And I'm going to get a flat hand, and I'm going to put it on the back side. And then I'm going to push in and up towards the ribcage. It should be a single motion. I'm going to do this maybe 5 times, 5 abdominal thrusts and 5 back blows, and it should be fine. Only if you are alone. If you're alone, I once did this to myself actually. شردقت على شقف الطاووق and it wouldn't get out. So I put my finger, the Heimlich maneuver, and I just shoved myself into a chair, and it was absolutely fine. So this is very effective. Trauma. Now we are getting down to business. So we are going to talk about the skeleton. We are going to talk about manual inline stabilization or manual inline axial stabilization. They're both correct, or we call it in Lebanon C-spine immobilization. We are going to talk about the trauma to the head and neck. We are going to talk about trauma to the arms and feet. The skeleton. This is the vertebral column. Now, what's interesting, if we take a look at here, this is the cervical part. This is the C-spine. This is
somehow session 10.
this is the L-spine. I am concerned over here. Let us play out a scenario. If I get punched, this is my neck, these are my shoulders, just like that. If I get punched anywhere over here, it's absolutely fine. There is good muscle, there are bones, there are organs, it's well protected. The problem is if I get hit in the head or sustain head injury, this is not protected. It can move left or right very easily. So this is why I'm going to hold the head and neck firmly so that it doesn't move left and right. This is why I do the C-spine immobilization. So when do we apply it? If we suspect head injury or neck injury, until it is cleared, we do this. Unconscious or comatose patient. In fact, when we are sleeping, we call it semi-comatose. When we are unconscious, it is called comatose. Need to establish a patent airway. We hold the neck firm and the head firm so that we know how to work. How do we do this? Okay, I want you to take both your hands and put them in front of you and put your palms facing each other. Now, I want you to open your hands and fingers to the full extent. This is ready for Mias or Mills. If I'm going from the back, مثل ما حاطين هون, I'm going to put them on left and right. My fingers are going to go between, they're going to let the ear be in the middle. And my pinky it's going to be at the bottom of on the top part of the neck, and my fingers, they are going to be on the forehead. It is similar to what they're doing here. If it is from the front, I am looking at the person the right way. I'm gonna put my fingers facing the top of the head, my thumbs on the jaw, and my pinkies on the skull base. That's the other way around. هون مثل ما شايفين they are doing something called intubation. This is called a laryngoscope. This to view the larynx before they put a tube in. Normally the patient cannot protect their airway. عم نعمل مياس over here. وهون عند probably anesthesia agents. وهون airway is open, the neck is fixed, and the head is stabilized. طيب هلا, how do we identify head injury or neck injury, potential neck injury? أول شيء we have scalp wounds over there. Can be from the top, from over here, or from the هيدا. وإذا ضربة قوية that made a big impact مثلا حاد السير, it can be causing something inside under the skull. We will take a look at it now. A fracture over here. This, when you have a black eye, this is called raccoon eyes. When it's black, معناتها there is some type of injury to the optical orbit. This is called the optical orbit. The black eye is called the raccoon eye, and it's a hint that there's something that's not right. Nasal discharge, nosebleeds. هدول بنسميهم epistaxis. Epistaxis, and we're going to take a look at those in another course, in another workshop. A swelling or bruising. This area over here is called the maxillofacial area. And if there is a swelling or trauma to it, suspected head injury, وأكيد a stiff neck. So, it's simple. I do the C-spine immobilization. I will call for help because a head injury is no joke. Stop any bleeding before anything else. We're going to check the airway, and we are going to make sure that they are breathing. هلا, the nice thing about head injuries انه they speak for themselves. Nobody is hiding. فنحن فينا نعمل a neurological examination. Worst case scenarios هو هون. عندي this is called a subdural hematoma, which is normally البرين تبعنا. It is enclosed in a sac. If there is a bleeding between the brain and the sac, this is called a subdural hematoma. If it's between the sac and the skull, it is called an epidural hematoma. هون بيكون there is pressure over here عم يكبس على optical nerve. هون وهون. These pupils are unequal. This is a case اسمها anisocoria. Anisocoria. Okay. Anisocoria. When the pupils are uneven, and it's a sign of head trauma. Bandaging the head. I have two anchor points, which are the cranial and the mandible, وعندي واحد auxiliary من فوق. So let's see what we do. Please don't do this. Please don't do this. Many people, they have so much fun, بيجيبوا so much gauze وبيلف فرجاس from top to bottom. Don't do that. عشان you're just wasting resources. If we are wrapping it with a gauze wrap, we will do it like this, and we will leave the opposite ear open. This is for balance. وحتى ما نتضايق لما نحط headphones for a long time بيوجعنا راسنا. So we leave one ear relieved. If it's using elastics, ما بنشدها كتير. We just leave it firm to stop any bleeding, but not too tight. Let us see trauma to the arms and legs. We're going to control and stop any bleeding. And what constitutes as trauma? Dislocation from a joint, a twisted ankle, open fracture, or a closed fracture. Open fracture بيكون العظمة literally ظاهرة لبرا. And I didn't include any pictures, بس later I will بكون شوي تعودنا. فهون أكيد I'm gonna do some packing and wrapping very efficiently. كتريتمنت you'll need a hospital either way. We do not put the bone back عشان if I try to put the bone back أول شيء it's gonna be painful. تاني شيء I might injure myself. And the third thing while I'm putting it back I might sever an artery فوتني بمشكلة تانية, or I might sever the nerve. بصير it's a bigger problem. We're going to pack it well and we are going to cushion the bone. We are going to bandage it thoroughly. ولا in the next slide we're going to see how we splint, كيف بنعمل slinging. Expected characteristics of an open fracture هن defect in the tissue, a fracture which is the fracture is exposed to the outside world يعني, so there's a high risk of infection. فهون normally we would give tetanus or broad spectrum antibiotics. That will take care of it. A treatment, we're going to sling it, we can splint it, we can use a traction splint. A splinting, this is called a SAM splint. You can look it up. You can reuse it and clean it. هون فينا نشوف الشيب of the SAM splint. هون it is like this. هون it is like this مثل measuring tape. هون they are improvising. They are using a cloth to tie it. هون they're using some type of other type of splint. Traction splint using the traction to mimic the bone activity. هون عندي tension that's pulling the leg towards me. NASA, I think there are people who got out. ما قدروا يفوتوا. ماشي الحال شكله. Okay. And the belt and ratchet to pull it towards me. Only for the elderly osteoporosis, the bone is too weak to experience traction. And the proximal or distal fractures of the femur is a big bone. It's going to be very painful. We use it for tib fib fractures and to reduce pain in the lower part. Cardiac arrest. أحلى شيء. But wait, I think some people are losing connection. But let us take care of that really quick.
Excuse me, the internet is really bad. When you will download the session, where will it be?
We're just gonna wait a few minutes. ناخد بركي شوية break عشان some people are experiencing problems.
Excuse me. Can you hear me? Excuse me.
We're just waiting for a few minutes عشان some people are having internet problems.
Yes, I have a question. Can you hear me?
Okay, هنكفي my cardiac arrest. Fine. Let us take a look at what's going on in the heart. Over here, I have the SA node, sinoatrial node. هون عندي AV node, atrioventricular. The electricity to power the heart basically is going to jump from here to here, and then it's going to travel down the septum. هون عندي شيء اسمه the His bundle, and then it's going to go onto the Purkinje fibers to excite the heart. What happens sometimes is we have a disease with ectopic cells, and the heart just ceases. It no longer pumps. The muscle just vibrates. So fibrillation, معناتها vibration or ceased movement. And the two types, and the AFib and VFib. AFib is atrial fibrillation, and VFib is ventricular fibrillation. هلا هنشوف عشان this is the part that mainly is responsible for the systemic circulation. That's the part responsible for the systemic circulation, and that's the part that we are going to be pumping. Compressions only CPR. أول شيء we would give rescue breaths and whatnot, but then they said, no, it is okay, you can stick to compressions only CPR. Fine. Let's take a look at what's going on. Rapid evaluation. تتذكروا the carotid artery and the neck. We are going to check that for 10 seconds to make sure إنه عن جد ما في pulse. إذا ما في pulse, we're going to call for help. بعدين compressions, compressions, compressions. We are going to do compressions that are fast and deep. We need to literally go in 5 centimeters into the chest when we're doing compressions. And what we do, this is the chest, this is the person. My hands are over here. My elbows are locked straight. This is where I am. The elbows are locked straight, and I'm using my body weight to start compressing the chest. And I'm going to be counting 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. I keep on doing it until help comes, or because it's something very laborious of CPR, I enlist someone, and as they're performing CPR, I will tell them, I would start adjusting them quickly. أهم شيء is to do compressions, compressions, compressions. Afterwards, we will shock the heart back into the rhythm. Good Samaritan laws. The US and the UK and all other countries that respect themselves, they tell you, if you delivered CPR and you broke ribs and they punctured lungs or whatever, we will not prosecute you. This is a Good Samaritan law. هون بلبنان, sometimes even medical doctors بخافوا يعملوا CPR بنص الطريق because we do not have any Good Samaritan laws. If you cause damage to the person but they still live, they're still going to prosecute you. But this is the flow chart of what goes on. Person down, is the scene safe? If it's not, stand back and call for help. If it is, we're going to check the pulse. No pulse, we start compressions. If there is a pulse, we're going to check, are they conscious and responsive? No, we're going to put them into the recovery position. And if they are, we're going to identify the mechanism of injury or the nature of illness, and we are going to stop bleeding, open the airway, and whatnot. Let's take a look at the automated external defibrillator. If you like to push buttons and stick stuff, that's the machine for you. When the patient goes down, I'm going to get the AED. It has a button. It will tell me, attach, plug in the leads. I'm going to plug in the patches, and it will then tell me, remove all clothes from chest. Remove the clothes from the chest so that we can see the area that we are working with. Place the leads on the chest. And each lead tells you where it should go. It will tell you to hold CPR so it can analyze. It's going to analyze the rhythm. And either it will tell you shock advised, it will charge, and then we push this button that will beep in red, and you stand back. You stand back from the person because if it delivers a shock and you're touching the patient, you're going to get electrocuted. If no shock, continue CPR. هون بس we forgot to add a part and jewelry. Okay. So first thing, I'm gonna remove all the clothes from the body. I'm going to start CPR until the AED comes. Once the AED comes, I'm going to plug in the leads. I'm going to turn it on. I'm going to listen to the instructions very carefully. Place the leads on the chest, stop CPR, analyzing rhythm, shock advised, stand clear. By then it will make like a beeping sound so that everyone knows to stand clear. It's going to deliver the shock. The thorax of the patient is going to jump up and it will say shock delivered, continue 5 cycles of CPR. We continue CPR. And at this point, we should be transporting Yani. If no shock is advised, we're going to continue CPR and we are going to also be transporting at the same time. In the medical setting, شو بيصير? Let us get an idea. هون عندي ECG leads or EKG. EKG is because it's German. هون نقولها cardio. هون it's German فبنقول cardio. Okay. هون عندي the ambo bag. هو normally when it's not hands or compressions only CPR شو بنعمل؟ نعمل 30 compressions to 2 rescue breaths. فthat's the ambo bag. وشو كمان في هون؟ ايه that's it. مش مبين أكتر من هيك. And the next picture هون عندي مثلا bag valve mask system عندي الintubation tube. هيدي we put it down the throat to secure it and to secure the airway as we give breaths. هون عندي my physiological monitor. I have my physiological monitor. هون شايفين فينا عم حاطين IV an intravenous catheter. هون عادة we put in شو اسمه epinephrine so that we can help jumpstart the heart. Funny thing is, it hasn't exactly been proven to jumpstart the heart, but because of what it does, we administer it. And the last part is what happens بلبنان national issues. The lack of medical knowledge. People do things and it's wrong. بس إنهم مقتنعين بحالهم أنه they're doing the right thing, which is why it is important to read books. If you don't know what to do, don't do it. You are responsible for what you know. Lack of good Samaritan laws وcultural problems. يعني مثلا when I was working in emergency services, we would go to a patient's house and it would be a woman, a middle-aged woman, and to do CPR, you need to expose the chest. You need to expose the chest to see what you're working with, if there is a pacemaker, if there are any, there's something odd, whatever. So we expose the chest and you need to do CPR. You need to remove the bra مثلا. You need to remove all of that عشان the bra sometimes is lined with metal. It can cause a short. So what happened was that they said, no, you need to wait for her to put on the veil before you start CPR. And with all respect, we let them do that. Our hands are tied, but the, these cultural problems come as a limit when it comes to medicine, because CPR should be initiated very fast and very efficiently. طب هلا I'm going to show you how to prepare your own med kits. We have different configurations. We have an IFAC, which is called an individual first aid kit. We have a blowout kit, which has everything and the only things that you need for bleeding only. You have an urban casualty response, or UCR. When we have more advanced workshops in the future, we are going to discuss it. tactical medical practitioner, the TMP kit. That's probably the last workshop I would give in tactical medicine. So let's take a look at the IFAC. This is my IFAC, for example. It's a little bit larger than my hand, so my hand would come in like over here. Okay, so I have tape, tongue suppressor, bandage, scissors. I have a glow stick. I have two tweezers. I have wrapping bandage. This is called an Olias moderate hemorrhage bandage. We will see this later on. At the This one is a nasopharyngeal airway. It's a tube that we put inside the nose um, if the person is going to regain consciousness. A thermal blanket for hypothermia. We will discuss it later. And I have 10 4x4 gauze and two wrapping gauze for packing and just applying the pressure, and an eye shield for eye injuries. And in the future, probably next week, we are going to have another workshop, which would either be pre-hospital trauma